Um, so we're going to talk about diastolic function, and diastolic function has been ignored for a very long time. People are only concerned about systolic function because you're interested in knowing how the heart is providing adequate cardiac output and blood flow to the tissues. So people ignored diastole for a long period of time, and it wasn't until about 30 years ago that people started thinking about diastole as an important part of cardiac function, overall hemodynamic function. And they started investigating it in a little bit more detail. I'm not able to advance the slide. There it is, thank you. So what about diastolic function? Well, the function, what happens during diastole is that when the ventricle relaxes, the ventricle gets filled with blood from the atrium. Okay, so for the left ventricle, the blood comes from the left atrium to the left ventricle through the mitral valve. If relaxation is not complete, one of two things can happen. One is that it doesn't fill adequately. So that means the preload is decreased, which will decrease cardiac output. But more importantly, what happens is that if you try to fill the stiff ventricle, the only way you can fill it is by increasing the pressure. And so the end diastolic pressure will go up. And with increase in end diastolic pressure over a period of time, lasting months to maybe years, there's an increase in left atrial pressure, which is reflected back into the pulmonary circulation, causing pulmonary venous congestion and symptoms of congestive heart failure. People didn't realize that congestive heart failure can happen with impaired diastolic relaxation, and people thought that congestive heart failure occurred only when there's systolic dysfunction and there's a decreased cardiac output. It turns out that approximately a third of the patients who have symptoms of congestive heart failure have normal systolic function, normal cardiac output perhaps, normal ejection fraction, but they'll have impaired relaxation, impaired diastolic function, and symptoms of congestive heart failure. Over a period of time, this increase in pulmonary vascular pressure can also cause right heart failure and go on to cause backward failure such as ascites, bilateral pitting edema, enlarged liver, jugular venous distension, all those classical symptoms and signs of congestive heart failure, mainly dyspnea on exertion, paroxysmal nocturnal dyspnea, and easy fatigability, and so on and so forth. So diastolic function is an important aspect of the overall hemodynamic function, and you need to be able to evaluate whether the reason for diastolic failure, dysfunction is what is causing congestive heart failure, because your treatment might somewhat vary. In general, the treatment is about the same. You give diuretics and some amount of fluid, but if it's systolic dysfunction, you will actively promote vasodilation by giving some ACE inhibitors or angiotensin receptor blockers, like I showed you before. But if it's due to diastolic dysfunction, you may not rely so much on vasodilators. You might rely more on diuretics. So the treatment of these patients also is somewhat modified by your diagnosis or your etiology of congestive heart failure. So how do you measure diastolic function? Well, as I said before, diastole is when the ventricle relaxes and the ventricle is filled. If you want to monitor left ventricular diastolic function, you look at left ventricular filling characteristics. Filling occurs through the mitral valve. So if you have impaired filling of the left ventricle because of impaired relaxation, that will be reflected in the blood flow through the mitral valve or the transmitral flow. So if you measure the velocity of transmitral flow using Doppler, you can get some idea of diastolic function. People have now refined this technique and said if you measure the myocardium adjacent to the mitral valve, you can either measure the septal myocardium or the lateral wall, and see how it moves with changes in transmitral flow. That will also give you some index of diastolic function. And nowadays, people think that the tissue Doppler velocity, that is myocardial movement, is much more sensitive than transmitral flow. But for practical purposes, when you do it clinically, we look at both transmitral Doppler velocities and tissue Doppler velocities of myocardium adjacent to the mitral valve to diagnose diastolic dysfunction. Now I'm going to go through the basics of what diastolic dysfunction is and how it's reflected in transmitral flow and tissue Doppler velocities. I'm not going to go into great detail, but it'll give you a little taste of what we can do to look at the diastolic function of the heart. It's mostly done with echocardiography, and this is an echocardiographic image taken from a transesophageal echocardiogram. So this is the echocardiogram shown on the top, and here are the flow velocities. Here's a left atrium. The probe, echocardiographic probe, is situated in the aorta, in the esophagus, right behind there, right where the green laser pointer is. Here's the left atrium, the mitral valve, and the left ventricle. So during diastole, the mitral valve opens, and the left atrial blood goes into the left ventricle. And this little two lines that are shown here is known as sampling volume. You don't need to know what that means right now, but we are measuring the velocity of transmitral flow right at this point. You can also move this cursor to the myocardium on the septum or the myocardium in the lateral wall and measure tissue Doppler velocities as well. So let me take you through this profile and show you what happens during diastole and what happens during systole. Now shown here in faint outline, I hope you can see it, is the electrocardiogram in the patient, which is superimposed on spectral Doppler. You can see the P wave here, followed by the QRS, followed by the systolic portion, comes the T wave right here, and the beginning of diastole. To the next atrial contraction, the next QRS complex. You know that QRS represents ventricular contraction. So ventricular contraction starts from here and lasts till about the T wave. So this is systole. What happens to mitral valve during systole? The pressure in the ventricle is so great, the mitral valve is closed. It's not open. There is no flow taking place from the left atrium to the left ventricle at that time during systole. At that time, the left atrium is getting filled with blood coming from the pulmonary veins. So you have venous return coming to the left atrium, but the mitral valve is closed, and there is no transmitral flow. And that's what you see here. There is no transmitral flow. Incidentally, because the probe is here and the flow is taking place away from the probe, the flow velocity profiles are shown below the baseline. This is the baseline. The flow velocity profiles are shown below the baseline. Okay? So there is no flow below the baseline during systole. See, there is zero flow. At the beginning of diastole, left ventricular pressure decreases dramatically. Left atrial pressure with venous filling is much higher than the left ventricular pressure. And during early part of diastole, the mitral valve opens passively due to the pressure difference across the two chambers. And the blood flow goes from the left atrium to left ventricle in a sudden gush, and that is shown by this particular wave pattern, right? This one. It's shown as E, it's called E wave, denoted by capital letter E, and that E stands for early diastolic filling. It takes place during early part of diastole, passively without any atrial contraction. At the end of diastole, just before the onset of systole, the atrium contracts and pushes the last few cc's of blood into the left ventricle. So the atrial contraction is shown by the capital letter A. So this is the E wave, and this is the A wave. E wave, A wave, E wave, A wave. In normal people, 90 to 95% of the ventricular filling takes place during early diastole due to passive filling. Only 5 to 10% of the ventricle is filled due to atrial contraction, or what is called the atrial kick. The atrial kick pushes the last 5 to 10% of the atrial blood into the left ventricle. So normal situation, the left ventricle depends on passive early diastolic filling for most of its end diastolic volume. If you have increased stiffness of the ventricle, impaired diastolic relaxation, then the ventricle starts to depend more on atrial kick to fill it. The amplitude of the A wave goes up significantly in relation to the amplitude of the E wave. Excuse me. So the E to A amplitude, or the ratio of E wave to the A wave, will give you some measure of diastolic function. You can also look at, as I told you, tissue Doppler velocities, and it turns out that the movement of myocardium, either in the septum or in the lateral wall, is in the opposite direction, and the amplitude of these movements are much smaller than the amplitude of the waves that you see with transmitral flows. And that is shown on the next slide. Here on the right panel is transmitral pulse wave Doppler flow velocities. On the left panel are shown the tissue Doppler velocities of myocardium. The movement of myocardium towards the probe in the opposite direction is also termed E, but here is denoted by lowercase or small e. Here it's capital E, here it is small e. There's also a little dash of what looks like an apostrophe. It's not called E apostrophe, it's in echocardiographic parlance, it is called E prime. When you say E prime, you're talking about tissue Doppler velocity. When you talk about E wave, you're talking about transmitral flow velocity. Again, this is called E prime when you're verbally trying to convey your Doppler velocity. When you say E prime, you're talking about tissue Doppler. When you talk about E wave, you're talking about transmitral flow velocity. So this is a patient with normal diastolic function. Look at the E wave is taller than the A wave, and that's what happens. E to A ratio is pretty close to 1 in normal people, sometimes maybe greater than 1. But when you have impaired relaxation, your E wave goes down and the A wave becomes much bigger. The E to A ratio gets reversed. And that's because the stiff ventricle cannot fill passively. It relies on the atrial kick to provide most of the filling, and the E to A ratio becomes reversed. It's also reflected in tissue Doppler velocities. In normal situation, the tissue Doppler E prime is greater than 10 centimeters per second, or the ratio of E wave to E prime is less than 8. Okay, so that's what happens in normal patients. If you have impaired relaxation, the E velocity becomes significantly less. E prime is less than 10 centimeters per second. The E velocity EA ratio is reversed here as well. And the ratio of E to E prime becomes less than 8. With further diastolic dysfunction, greater degrees of diastolic dysfunction that I won't go to, it's called pseudonormalization, restrictive pattern, and so on and so forth. These denote significant diastolic dysfunction, severe diastolic dysfunction. The changes in pattern are also very distinct, and you can diagnose all those things. This is called pseudonormalization, this is called restrictive pattern. I won't go into all details about that, but again, E to A ratio, E prime to E ratio, all those things will give you some measure of diastolic dysfunction. So this is how we measure diastolic dysfunction intraoperatively with echocardiography, but more commonly when you send a patient for echocardiogram, you can also do this transthoracic echocardiogram. In fact, if you see a detailed transthoracic echocardiogram report coming from the echocardiograph laboratory, you will see ejection fraction as a measure of systolic function. You'll also see either tissue Doppler velocities or transmitral flow velocities to give you some measure of diastolic function. And quite often in the summary, they'll say there's some diastolic, mild diastolic dysfunction or moderate or severe diastolic dysfunction. So we use it clinically as well. And this is how the clinical parameters are judged by Doppler velocities of either transmitral flow or the tissue using echocardiography. So with that comes, I come to the conclusion of measuring cardiac function itself, both during systole and diastole. And now we're going to go on to the peripheral circulation, which is quite often ignored when you talk about cardiac physiology, but we are really interested in that because remember, we talked about the purpose of the cardiovascular system is to supply oxygenated blood to the tissues, and we are really interested in knowing what the tissue blood flow is. So we're talking about regional blood flows, and we won't talk about all the regions. We'll talk about important organs such as the heart, brain, and the kidneys. Okay. It turns out that regional blood flows are fairly well regulated by the body itself. Each organ regulates its blood flow over a range of perfusion pressure. And this curve is known as the autoregulation curve. And a lot of us confuse and think that autoregulation only applies to the brain. And that's because we talk about autoregulation of cerebral blood flow all the time. But every tissue bed in the body has autoregulatory capacity. And I want to emphasize that. And I want to walk you through this autoregulation curve. Shown on the horizontal axis is blood pressure or perfusion pressure. Shown on the vertical axis is blood flow to this particular tissue or organ. Let's assume a patient who's got normal pressure of, say, 80 or 90 mean arterial pressure, and the flow is right there is normal. If you suddenly decrease the pressure from, say, 90 to 70, the immediate response is for the blood flow to decrease, but within a matter of a minute, in fact, within a matter of seconds, the vessels in the organ will vasodilate and will restore the blood flow back to normal. If you decrease the pressure even further, it may come back a little bit, but it doesn't come back to normal because it is now beyond the lower limit of autoregulation for this particular tissue. Over a range of perfusion, in this particular example, over a range of pressure from about 70 to about 160, the blood flow is maintained reasonably constant. Below that pressure, the blood flow rapidly declines, and above the pressure, the blood flow goes up. If the blood pressure is decreased, the vessels will vasodilate to increase the blood flow. If the blood pressure increases, again, you have the transient response here. The blood vessels will constrict and restore and bring the blood flow back to normal. So this strip line or the dotted line show the transient response to blood flow, to changes in blood pressure, and the solid line shows the final autoregulated response to the changes in pressure. The important thing, as I mentioned before, every organ in the body, including muscle, will autoregulate blood flow. And this autoregulation is a local phenomenon, is independent of nervous connections of the organ or the tissue bed itself. If you completely denervate the organ of its autonomic blood supply, both parasympathetic and sympathetic, it will still show autoregulation because it's a local myogenic response that causes vasodilation and vasoconstriction. This is shown on the next slide. This is a very classic picture taken from an article that was published in Journal of Applied Physiology almost 50 years ago, and they show autoregulation of blood flow in the kidney, in the brain, in the coronary blood vessel, and also in the skeletal muscle. And we'll ignore this because it's not important to us. We're concerned mostly about blood flow to the brain, kidney, and the heart. And you can see in the kidney, it shows the transient response and the final response here. Okay. Notice that the blood flow is maintained over a range of perfusion pressure, and it starts to decrease when the pressure decreases further. You can see it in the heart as well. Over a range of perfusion pressure, the coronary blood flow is maintained and then it starts to decrease. Same thing happens in the brain. What I want you to look at in this particular set of slides is the lower limit of water regulation. Look at the kidney. The lower limit of water regulation is something like 70 millimeters of mercury. Below that, it starts to decrease. At 60 millimeters, it's already decreased. At 50, it's even lower, and so on and so forth. The lower limit of water regulation of the kidney happens to be about 70 millimeters of mercury. For the heart, it turns out to be about 60 millimeters of mercury. It starts to decrease before that. And for the brain, it's even lower. It's about 50 millimeters of mercury. And that makes sense because you want to preserve the brain. You can live with no kidneys. You can get dialyzed and live without kidneys, but you can't live without a brain. So the body tries to preserve brain blood flow at very low levels of blood pressure. And this is something that is built in nature so that you have adequate perfusion of the brain at the expense of other organs. How do they measure coronary flow here? Well, coronary flow, as we are all taught in physiology, is more dependent on myocardial metabolic needs, and the oxygen consumption of the heart goes up, myocardial oxygen consumption goes up, the coronary blood flow will also go up. And that's because even under normal circumstances, the myocardium extracts almost all of the oxygen from the arterial blood, so that if you increase myocardial oxygen demand, it cannot increase oxygen consumption by extracting more oxygen from the venous blood. It has to increase the myocardial blood flow to meet the increased oxygen demand. So it varies quite a bit with oxygen demand. So how did they measure coronary blood flow in this particular situation? They did this in what is known as an isolated heart preparation called the Langendorf preparation. In a Langendorf preparation, you take the heart out of the animal. Of course, you can't do it in human beings. You take it out of the animal quickly and perfuse it with nutrient solution that's well oxygenated. The heart muscle will still be alive and it will still contract. If you perfuse the coronaries with the nutrient solution that contains ATP and well oxygenated, heart will continue to contract, and it's called the Langendorf preparation, and a lot of studies have been done on Langendorf preparation. Now you can arrest this Langendorf preparation by infusing the coronaries with a solution, with a nutrient solution that is high in potassium. You know that potassium will produce a diastolic arrest. So here's a Langendorf preparation that is perfused with a nutrient solution that contains high levels of potassium, and the heart is arrested. And then you measure coronary blood flow in this arrested heart, and you can still see autoregulation. So this is a completely denervated, isolated organ that is showing autoregulation even when it's completely arrested. So that is the point that I was trying to make. Autoregulation is a local property. It is seen in isolated organ preparations. It is independent of any nervous connection to it. Central nervous system connection, either sympathetic or parasympathetic. And the lower limit of autoregulation is there to prevent damage to vital organs at the expense of organs that are not so vital. Kidney is vital, but we know in current practice, you can survive without a kidney. You can get dialyzed, but you cannot survive without a heart transplant. If the heart goes, it's difficult to get a heart transplant. If the brain goes, you're pretty much dead. Nothing can happen. So the brain is protected at much lower levels of pressure, whereas the heart and kidneys may suffer decreases in flow with decreases in pressure. There's further protection built in nature, and that is below the lower limit of water regulation, the blood flow will decrease. In the previous slide, I showed you here, and it's a pretty linear decrease. Below the lower limit of water regulation, it's linear. That is, for a given change in pressure, the flow will decrease proportionately. So if you assume that below the lower limit of water regulation, the blood flow decreases, you will not see signs of ischemia till the blood flow itself is decreased by 30 to 40%. There is even further protection built in this system. Some classical studies done in Mayo Clinic using patients, measuring cerebral blood flow, they were able to demonstrate that cerebral blood flow itself has to decrease by 30 to 40% before you see signs of electroencephalographic slowing of the EEG waves. You see delta waves when the blood flow, cerebral blood flow decreases by about 30 to 40%. When you decrease it to 50%, you start to see burst suppression. When you decrease it greater than 50%, you see isoelectric EEG line showing irreversible ischemia. But at levels of blood flow that is 30% below normal, you may not see ischemia at all. So there is further protection built into nature for protecting the organs and the vital tissues. Now, all bets are off. This is assuming that the blood vessel that is supplying all these organs is undamaged. If the blood vessel is itself stenotic, if it has an intravascular stenosis, intraluminal constriction due to an atheromatous plaque, then it's you can no longer measure arterial pressure in your brachial artery and assume that the pressure perfusion the organ is the same as the brachial artery pressure, because pressure distal to the stenosis is going to be significantly less. So if there's a stenotic lesion in the vessel, the pressure distal to the stenosis is going to be significantly less, and that becomes the perfusion pressure of the organ, and you cannot predict what the perfusion pressure is because you don't know if the vessel is stenosed. And further, if you don't know the degree of stenosis, you don't know how much of the pressure drop there is. So even though autoregulation preserves blood flow, you cannot always predict that the organ is well perfused because the vessels perfusing the organ may be diseased, and you cannot rely on autoregulation to estimate adequate blood flow to the organs. So that is the proviso, or that is the caveat that you have to take when you assume there is autoregulation to the flow of flow to the tissues, and the tissues are well oxygenated, are supplied with well oxygenated blood. Now, I want to go a little bit further and talk about myocardial blood flow with particular reference, because as I said before, myocardial blood flow in the arrested specimen that I showed you before, the Langendorf preparation, shows autoregulation, but in a beating heart, the blood flow is more regulated by the oxygen demands, and the blood flow to the different parts of the myocardium is not uniform. So if you look at the perfusion pressure for myocardial blood flow, we talked about a simple hydraulic model where the perfusion pressure is the difference between the proximal and distal pressures. For the myocardial blood flow, the proximal pressure is the coronary artery pressure in the coronary artery that is supplying the blood to the myocardium. The distal pressure becomes the ventricular pressure, because the myocardial vessel, the coronary vessels are epicardial. They penetrate the myocardium and go towards the lumen to supply the myocardium. And the luminal intraventricular pressure is transmitted to the tissues, and that becomes the P2, or the distal pressure that opposes coronary blood flow. So the perfusion pressure for the myocardial blood flow will be coronary artery pressure minus ventricular pressure. This is important because different regions of the myocardium have different perfusion pressures, and that is shown on the next slide. Let's assume somebody who's got a normal systolic arterial pressure of 120 over 70 millimeters of mercury. The perfusion pressure for left ventricular myocardium during systole is coronary artery systolic pressure minus left ventricular systolic pressure. We know the coronary artery systolic pressure is same as systemic systolic pressure, is 120. And in normal people with a normal aortic valve, the left ventricular systolic pressure is the same as the arterial systolic pressure. If anything, the left ventricular systolic pressure is a few millimeters of mercury more than the arterial systolic pressure, so that it can eject the blood. So the pressure gradient during systole for the left ventricular myocardium is 0. And that is why there is no blood flow taking place during systole to the left ventricular myocardium. All of the blood flow to the left ventricular myocardium takes place during diastole, because the diastolic coronary artery diastolic pressure is 70, same as systemic artery diastolic pressure. The left ventricular diastolic pressure is about 10, and you have a significant perfusion pressure gradient for coronary blood flow to occur. Now let's go to the right ventricle and see what happens. The right ventricle is supplied mostly by right coronary artery, and the right coronary artery pressure is the same as the left coronary artery pressure, same as the systemic arterial pressure. So during systole, the systemic coronary artery systolic pressure is 120. The right ventricular systolic pressure is only 25 in normal cases, because right ventricle is a thin-walled chamber. It doesn't have to generate high pressures to eject blood into a low pressure, low resistance pulmonary circulation. So the peak pressure is about 25, and you have a significant pressure gradient flow into the right ventricular myocardium. In fact, in a lot of studies, blood flow to the right ventricular myocardium is greater during systole than during diastole. The pressure difference, the perfusion pressure during diastole for the right ventricle is coronary artery diastolic pressure minus left ventricular diastolic pressure, which is about 65. The point is that when we talk about myocardial perfusion, we always talk about left ventricle. Left ventricular myocardium. When you talk about myocardial infarction, we talk about myocardial infarction in the left ventricle. But myocardial infarction can occur in the right ventricle too. It is not very common, but it can happen. And if it happens, it's because your systolic and diastolic flow to the right ventricular myocardium is significantly reduced. Let's take another example of a patient who's got significant pulmonary hypertension without any systemic hypertension. And that's possible. There are cases where there is pulmonary artery pressure goes up without an increase in systemic arterial pressure. The classic examples are Eisenmenger syndrome, patients with severe COPD without any increase in systemic arterial pressure, patients with severe mitral valve disease that have pulmonary hypertension but no systemic hypertension, patients with idiopathic pulmonary hypertension who have normal systemic arterial pressures. In those cases, the pressure flow dynamics to the right ventricular myocardium is altered quite significantly. Let me show you an example. The right ventricular myocardium, as we said before, gets all its blood supply during diastole, and the perfusion pressure for the left ventricular myocardium is diastolic pressure minus left ventricular end diastolic pressure. For right ventricle, the myocardium gets blood supply during both systole and diastole. And if you take a patient with severe pulmonary hypertension with normal systolic arterial pressure of 120/70, but has a pulmonary artery pressure of 80/40, that is moderate to severe, not that bad. The patient is still alive, is still functional. If you look at the RV myocardium during systole, now the pressure gradient is significantly different, because the right ventricular systolic pressure with the PA systolic pressure of 80 is also 80. Because the right ventricle has to develop a pressure of 80 to be able to eject blood into the pulmonary artery. So coronary artery systolic pressure is 120, same as systemic artery systolic pressure. The right ventricular systolic pressure is 80. So the gradient during right ventricular for perfusion of right ventricular myocardium during systole is significantly reduced, and there is significant reduction in systolic flow to the right ventricular myocardium. Now imagine if you take this patient and you anesthetize this patient and you give them some anesthetic agent that drops your systemic arterial pressure. If the systemic arterial pressure drops significantly and your systolic pressure goes even lower than this, if it approaches pulmonary artery systolic pressure, you will have no gradient for perfusion during systole, and the right ventricular myocardium will undergo ischemia and acute dysfunction and failure. And this happens all the time. Because in patients with severe pulmonary hypertension, especially patients with idiopathic pulmonary hypertension, Eisenmenger syndrome, you can drop your systemic pressure during anesthesia, but all the anesthetic agents will not alter your pulmonary artery pressure. It may bring it down a little bit, but will not alter it. your systemic pressure will go down significantly, causing right ventricular ischemia, especially during systole. So in this case, if you want to, so in patients with moderate to severe pulmonary hypertension, it is important to maintain systemic arterial pressure to ensure adequate perfusion of right ventricular myocardium during systole. So how do you do that? If you have a patient with severe pulmonary hypertension and you anesthetize the patient and there's a systemic hypotension, which means that, in all these patients, I would put an arterial catheter and measure systemic arterial pressure very carefully. You can cause, if you have systemic hypotension, you can treat systemic hypotension using vasopressin because it selectively causes increase in systemic vasoconstriction with very little pulmonary vasoconstriction. Vasopressin doesn't cause pulmonary artery pressure to go up because pulmonary vascular bed does not have any vasopressin receptors. It causes systemic vasoconstriction, causing the systemic pressure to go up. So if you have a patient with severe pulmonary hypertension and you want to treat systemic pressures, the drug of choice is vasopressin. Norepinephrine, phenylephrine, and all those things will cause systemic vasoconstriction and pulmonary vasoconstriction as well. So vasopressin is the drug of choice. So in patients with severe pulmonary hypertension undergoing anesthesia, it is important to make sure that you don't do things that will trigger increases in pulmonary artery pressure. What are the things that will increase pulmonary artery pressure? Hypoxia, hypercarbia. Those are the things that increase airway pressure. All those things are going to increase pulmonary artery pressure. You want to minimize it. But you want to maintain systemic artery pressure, you have to put an arterial catheter, monitor blood pressure very closely beat to beat, and administer vasopressin in case there is systemic hypotension. It is not so important to measure pulmonary artery pressure by putting a PA catheter. It is, I think, more important in these patients to measure systemic artery pressure and maintain systemic arterial, normal systolic blood pressure and diastolic pressure. I'm going to stop there and summarize what I've told you in the last couple of hours. And what I've tried to tell you is that the arterial pressure is very important for maintaining blood flow and is regulated by a couple of mechanisms in the body. One is the baroreceptor mechanism and by the renin-angiotensin mechanisms, both of which will produce vasoconstriction, causing increase in resistance, cause an increase in blood flow by stimulating the heart. So both an increase in pressure and an increase in flow and an increase in resistance will increase blood pressure and restore back to normal. Increases in preload within physiological limit when the muscle is not stretched beyond the point where the actin and myosin filaments are no longer overriding each other will result in increased force of contraction, thus increasing cardiac output. And this is called the stalling mechanism. Contractility is a property of cardiac muscle in which the force of contraction is independent of loading conditions, that is preload and afterload. Increases in contractility and increases in preload will cause an increase in cardiac output, whereas increases in afterload will cause a decrease in cardiac output. Increase in contractility also increases cardiac output, and a decrease in contractility will cause a decrease in cardiac output. Afterload is a load against which the heart has to eject. Increases in afterload decrease cardiac output because it has to eject against increased loads or resistances. Ejection fraction is a reliable clinical index of systolic function. It reflects contractility and loading conditions. Diastolic function is an important measure of hemodynamic integrity, and diastolic function is clinically measured by transmitral flow velocities or by tissue Doppler velocities of myocardium adjacent to the mitral valve, and requires echocardiography to do that. And finally, regional blood flow is maintained over a range of perfusion pressure from about 50 to 160 millimeters of mercury by autoregulation, which is a local property that's independent of nervous system, independent of autonomic connections to the tissue bed. And finally, the right ventricular myocardium gets blood supply during both systole and diastole. And in pulmonary hypertension, decreases in systemic arterial pressure can cause significant decreases in blood flow and cause right ventricular ischemia and acute right ventricular dysfunction. Thank you very much.
Thank you, sir. It was certainly fascinating to know your insights into the physiological concept and how it is impacting our day-to-day practice. For our viewers, registration are closed as of now. Interested candidates can watch the lectures on Manipal Anesthesia e-learning channel on YouTube. E-certificates will be given to all those who have attended at least 4 days or more and have submitted the feedback form, which will be available from 8th November 2020. Now I request Dr. Sivarajan to kindly address the queries.
Hello, sir.
Hello?
Yes, sir. So here is the first question by Dr. Siddharth and Dr. Pooja, which says, explain the difference between contractility and contraction of the heart.
Difference between contractility and contraction of the heart?
Yes, sir.
They are related. Contraction of the heart is due to actin and myosin filaments forming cross bridges and sliding on each other, causing a shortening of the fiber. And contractility, as I said, is the increased force of contraction due to mechanisms that are outside of the loading conditions. In preload changes, what happens is the actin and myosin filaments slide apart from each other. They're not completely apart, but they're still overriding each other. I don't know if you can see my hand. So they are allowed to form cross bridges across. Whereas contractility is affected not by increased cross bridge formation, but it's ultimately affected by increased cytoplasmic calcium, mostly brought about by increases in calcium release from the endoplasmic reticulum by beta stimulation. So this increased calcium will cause increased binding of actin myosin filaments. And that's what causes increase in contractility without changes in fiber length or without increasing the distance between actin and myosin filaments, allowing more cross bridges to form. The cross bridge formation in contractility is due to increased cytosolic calcium, whereas the cross bridge, the increase in force of contraction with loading conditions is due to increased cross bridge formation. I don't know if that answers your question, but that is the essential difference between contractility and contraction.
So the next question is by Dr. Mohammed Sharif. The question goes, fall in perfusion pressure and sympathetic stimulation are opposite responses. How do both stimulate renin release?
Well, I don't know how the actual mechanism is, but it is known that sympathetic stimulation of the kidneys, of the nerves supplying the kidneys, for instance, the kidneys are innervated by sympathetic nerves coming from about T6 to about T10 segments, thoracic. And if you stimulate the sympathetic segments, these go through the hilum of the kidney, and if you put an electrode on the hilum of the kidney and stimulate that, you see a significant increase in renin output coming out of the renal veins. There's no question about it. In fact, part of the sympathetic response to surgical stress, to laryngoscopy, is mediated through renin release. Part of it is actual sympathetic response causes vasoconstriction, but part of it is also due to sympathetic stimulation of the kidneys causing renin release. I don't know what the mechanism is, but decrease in pressure is the autoregulatory response, is a regulatory response to restoring blood pressure, whereas a sympathetic stimulation causes renin release. I don't know the mechanism, but that's what it is. A decreased sodium delivery to the distal tubule is a mechanism to restore sodium levels in blood. So remember, if you have a decreased sodium delivery to distal tubule, the kidneys are going to increase renin release, and through aldosterone mechanism, it is going to allow for reabsorption, increase sodium level, and restore sodium level so the sodium delivery to distal tubule is now normal. So that I can understand, but I don't know why sympathetic stimulation causes renin release, but it does. It's a matter of fact.
So we'll go for the next question. Dr. Ravi Kiran wants to know, since left ventricular end diastolic volume cannot be measured, how do we obtain pressure volume loop?
Okay. Pressure volume loops are obtained classically by what is known in the old days. They used to do it only in animals. You couldn't do it in human beings. The way to measure pressure volume loop, remember you have to measure the volume in one cardiac cycle as the volume is changing. Okay, one cardiac cycle typically lasts less than a second. So within this 1 second, you have to describe the volume changes. And to do that, what they used to do in the old days was to open experimental animal's chest, implant ultrasonic crystals in different parts of the myocardium, close the chest of this animal, and with ultrasonic crystals embedded in various parts of the myocardium, they could measure the volume. Nowadays, they measure volume by putting what is known as a conductance catheter into the ventricle. The conductance catheter measures volume by looking at the conduction of electricity through the blood. Blood is a good conductor of electricity, and if the volume decreases during systolic portion of the cardiac cycle, less electricity will be conducted because there is less blood to conduct the electricity. So the conductance of the ventricular blood changes as the volume changes. And if you plot conductance over a cardiac cycle using complicated mathematical formulas, you can come up with a volume over a single cardiac cycle. This conductance catheter also has a transducer at the tip of the catheter that measures the pressure. So both the pressure and the volume can be measured during cardiac cycle. The volume by conductance of electricity through the ventricular blood, the pressure through the pressure to transducer, and that's how you do it. But as I said again, it is done mostly for studies. It's done in studies in animals all the time. In the humans, all the studies that are published are studies that are done mostly for experimental purposes in the cath lab. To do it in an ordinary lab, to float a catheter into the left ventricle across the aortic valve is very difficult. You can do it in the cath lab because you have fluoroscopy. You can look at the catheter and float it down through the femoral artery, through the arch of aorta, retrograde into the left ventricle. You leave it there for a few seconds to measure your pressure volume loop, but you can't leave it there for clinical monitoring purposes because it'll cause a lot of problems. It'll cause ventricular arrhythmias, it'll cause ventricular perforation, and it's just not practical to do so. That is the way of measuring left ventricular volume. It is by using conductance catheters.
The next question by Dr. Mohammed. He wants you to explain the trepe or the staircase effect.
Okay, I didn't want to go into that. Trepe effect is an effect in increase in force of contraction due to changes in heart rate. And it is presumed that it is due to the increased cytosolic calcium levels. So what happens during systolic contraction is that cytoplasmic calcium is released from the cytoplasmic reticulum. During diastole, this calcium is taken up again. There's reuptake of calcium by the cytoplasmic reticulum, so the calcium level decreases during diastole. If you increase the heart rate, there is less time allowed for reuptake of calcium. Cytosolic calcium levels stay increased. So during next systolic contraction, the increased cytosolic calcium levels will cause an increased force of contraction. That is the mechanism most commonly attributed to the trepe effect. The trepe effect is an increase in contractility due to increases in heart rate, primarily occurs because the diastolic duration is decreased. The reuptake of calcium by the cytoplasmic reticulum is less, is not complete. Cytoplasmic calcium level stays high, and during the next systole, there is increased force of contraction due to the increased cytosolic calcium.
We have one more question, sir, from Dr. Prithviraj. Does a transplant heart maintain autoregulation?
Transplanted heart?
Maintains autoregulation.
Transplanted organs?
Heart,
You
sir.
talk about,
Does a transplant heart maintains autoregulation?
of course it does. Even transplanted kidney, transplanted heart, transplanted pancreas will all maintain autoregulation. It all has autoregulation. They all remember, in the heart, most of the time it's not pressure flow autoregulation, it's metabolic. As I explained to you before, the heart controls its blood flow more by its metabolic needs. If you look at the brain typically extracts only a certain amount of oxygen from the arterial blood supply to it. If you look at the oxygen content of arterial blood supply in the brain, it's typically 20 ml of oxygen per 100 cc of blood. The venous blood coming out of the brain has 15 ml of oxygen per 100 cc of blood. So for every 100 cc of blood that goes to the brain extracts only 5 cc's of oxygen. If the brain metabolic rate goes up, if the oxygen demand of the brain goes up, such as during convulsion or say during fever, the brain can increase the oxygen consumption by extracting more oxygen from the arterial blood, so the venous blood will have less oxygen content. But that doesn't happen in the heart, because even in a normal condition, when the heart rate is say normal 70 beats per minute or 60 beats per minute, the extraction of oxygen from the arterial blood supply to the myocardium is almost complete. The coronary sinus blood has an oxygen content of 4 ml of oxygen per 100 cc. At that level of oxygen content, you cannot extract any more oxygen from the venous blood. The oxygen is tightly bound to the hemoglobin at this low level of oxygen, so you cannot extract any more. So if you increase the oxygen consumption of the myocardium by increasing heart rate, the only way you can get more oxygen is by increasing myocardial blood flow and not by increasing extraction. So the pressure flow autoregulation is not very commonly seen in a beating heart. I showed the experimental preparation where a Langendorf heart was arrested and they were still able to show autoregulation. And that's primarily an experimental example of all tissues maintaining autoregulation even when they're completely isolated. In a transplanted heart, the autoregulation is like any other heart. It is due to metabolic needs of the heart. In a transplanted kidney or transplanted tissues such as pancreas and liver, they will show autoregulation, pressure flow autoregulation.
So the last question for the day by Dr. Deepak Agarwal. Most of the echo reports show grade 1 diastolic dysfunction. Is this really significant to worry about?
Not really. A grade 1 diastolic dysfunction doesn't cause that much of a problem. You can overcome that by increasing fluid administration, maybe by giving, if it's really causing some problems with pulmonary congestion, you can go ahead and give some diuretics and solve that. It doesn't cause that much of a clinical hemodynamic problem. It's only grade 2 where there's pseudonormalization, or grade 3 with a restrictive pattern that causes really significant problems with pulmonary congestion and decreases in cardiac output. So grade 1 is something that's mild to moderate and that can be sustained in most of the clinical situations.
I think that was the last question, sir. Thank you, sir, for your comprehensive response. It's been a great pleasure to hear you refine our knowledge for a better and a safe practice. We are even more grateful and honored for your acknowledgement and presence to deliver this lecture at this odd time of 4 a.m. in United States. Kindly accept this e-certificate as a token of gratitude from the organizers.
Thank you very much. Thank you. I really enjoyed doing this. And again, I have lots of pleasant memories about being in Manipal. I worked in Manipal for a little over 2 years, between 1984 and 1986. Really had a great time there. I knew Dr. Ram Kumar at the time. I met Dr. Anita just as I was leaving, and it brings back lots of very pleasant memories. Thank you for affording me the opportunity.